Good morning, everybody. It's a great pleasure to be back with you again to do another live feed. Today's topic is going to be a very important and very interesting one. It's going to be on the effect of age and diminishing ovarian reserve on IVF outcome. Before I start, let me just say that those of you that are interested in talking to me online for a consultation should please contact my assistant, Patty Converse, and her number is 702-533-2691. You can call her directly and she will send you a questionnaire that she'll help you fill in if necessary. And then you can send that back to us and I'll have all the details about your history and circumstances. You should fill it in as detailed as you possibly can, but if you don't have all your records, that's not important, because there would be follow-up consultations where we can revisit on those things that I don't get. You can also make an appointment to speak with me directly online. And what you do is you go to the homepage of my blog, and when you get there, you'll see an invite to do a consultation. All you do is click on that, fill in the forms, submit them, and I will, and upon receiving that click, and upon Patty receiving this, she will reach out to you. She will call you and go over the questionnaire that she will send you. She'll then send you the questionnaire, and you should fill it in again diligently as best possible. Get it into us as quickly as you can, because there's a waiting list and I don't want you to wait too long to get in to speak with me. The third way to get an appointment to have a consultation with me on Facebook or on Skype is to send an email directly to Patty, and her email address is concierge@sherivf.com. It's CONCIERGE at sherivf.com. I really look forward to talking to you. I see I've spoken to almost 1,000 women since I started this process a year or two ago. So I've been pretty busy, and so far, based upon responses, I think the patients have been by and large satisfied that they've received detailed information that they can use to make informed choices. It's never my intention or my right to tell people what to do, but it is my responsibility to be transparent and to provide you information that you can use to make your own choices. Okay, let's get down to business here. We're going to talk about the effect of age and diminishing ovarian reserve on IVF outcome. On average, my patients tend to be older than the average patient. I would say the average age of my patients is probably close to 37 or 38 years of age. Whereas in general, the average age of women seeking IVF is in the low 30s, certainly under 35. And there are problems because as women get older, two things happen. Egg quality declines and they start running out of eggs. The decline in egg quality is irreversible and is independent of anything else. Doesn't matter how many eggs you've got or how many you produce, but as you get older, the likelihood that any of those eggs will be normal diminishes with age. A woman is born with all the eggs she's ever going to have. And these eggs are used up in batches every month. A certain point is reached, usually around the mid-30s, when those eggs start diminishing in quality. I use the word competency rather than quality. Competency meaning the ability to propagate embryos upon fertilization that will make a healthy baby. So after 35, things go down. And at the age of 45, you really are in trouble because egg quality is very poor. Let me give you an example. In women in their late 20s and early 30s, roughly 2 out of 3 eggs are going to be normal. That means they're going to have all the chromosomes that they're supposed to have at the point of their being released or extracted at IVF, egg retrieval. So when you get to 35, it's about 1 in 3. When you get to 40, it's about 1 in 5 or 6. At 42, 43, it's about 1 in 12. And when you get to the age of 45, only 1 in 20 to 25 eggs are going to be chromosomally normal. And if an egg is not chromosomally normal, if it doesn't have the optimum number of chromosomes needed, then that egg is referred to as aneuploid. Let me explain. Up to 36 hours before a woman ovulates, all the eggs have got the normal human genomic number of chromosomes, which is 46. 23 came from your mother's side and 23 from your father's side to make up an egg with 46. Then in the natural cycle, when the woman has an LH surge, which precedes ovulation, or when you give an analogous substance like HCG or Ovidrel, or if you force the woman to produce a surge in LH by giving an agonist like Lupron or Superfact to induce the maturation of the eggs go into a process we call maturational division or meiosis. During this ripening phase, which takes 36 hours, the eggs are forced to, or there's a stimulus to make the eggs reduce the number of chromosomes from 46 to 23. That's the objective at the time of ovulation or extraction. And this happens in that 36-hour window after the woman receives her trigger shot. So you need to understand that if an egg comes out with more than 23 chromosomes, even one more, or less than 23 chromosomes, even one less, such an egg is aneuploid. It's not the expected regular number. And such an egg, when it fertilizes with a sperm, will end up making embryos that are aneuploid as well. Remember, the sperm also goes through meiosis. So it reduces the chromosome number from 46 to 23. And so when the 23 from the sperm merges with the 23 from the egg, you end up with 46 back in the embryo. And if the embryo has even one more chromosome than 46 or one less, such an embryo is also aneuploid and incompetent, unable to propagate a baby. So it's very important that the egg go through an orderly meiosis, because most of what is at stake to produce an embryo that has got a normal chromosomal configuration that we call euploid, in distinction from aneuploid. Euploid meaning it's got exactly the right number of chromosomes. That is an extremely important situation in terms of propagating a baby, because embryos that are aneuploid will stop dividing very often and not ever reach the advanced blastocyst stage, or they will divide and they will not attach as blastocysts, or they will attach and miscarry and be lost early on in pregnancy as a chemical pregnancy or an early pregnancy loss or miscarriage. Those that do go on sometimes have abnormalities affecting specific chromosomes that lead to birth defects like Down syndrome. So what happens with the egg is critical to the outcome of the embryo and therefore of whether you'll have a viable pregnancy or not. It's not the only factor, by the way, but it's 70% of the story. And it's therefore important to do everything possible to make sure that the eggs retain their chromosomal integrity before being fertilized. We'll get back to that in a moment. Now, this concept that if for any reason the eggs have aneuploidy, they have more or less than 23 chromosomes, will lead to a disaster, is central to the way in which patients should undergo IVF if they're older, or if they've got diminished ovarian reserve, and you'll understand that better in a few moments. Now, because there is a decline in egg competency as women get older, and because it's the egg and not the sperm that is central to whether or not the embryo is going to be euploid and able to be competent to propagate a baby, it's very important to understand that age creates a pseudogenetic situation through wear and tear that means that it impacts on the ability of a woman to either get pregnant, to retain the pregnancy, or to end up with a healthy baby. That's why the older a woman gets, the lower the chance she will get pregnant, regardless of how many eggs she produces or how beautiful they look under the microscope. And it's the reason that women miscarry more commonly as they get older, especially into their late 30s and early 40s and beyond. And it's the reason we see more birth defects linked to chromosomal abnormalities, primarily an age issue, such as Down syndrome, as women get older. But there's another thing that's important to consider. We've just spoken about the effect of age, and there's nothing you can do to reverse that. A woman never makes more eggs. It's the eggs she's born with, and those are the eggs she'll use for the rest of her life. But, as I mentioned, as she moves along, using them up every month, she reaches a critical stage, which can vary from woman to woman. Some women won't reach this stage even until their mid-40s, while other women will have this happen much younger. And that is the critical threshold level where the number of eggs left in the ovaries falls below that threshold. And when that happens, the woman's pituitary gland, which is situated at the base of her brain, tries to cause more eggs to be formed, and it does this by releasing the hormone FSH, and more FSH is released, the fewer eggs in the ovary. It's like the mule driving effect I often refer to. The mule driver cracks the whip louder and harder in order to get the mule to move if it's moving slowly. So the pituitary cracks the whip by releasing more FSH as the ovary has fewer eggs in a futile attempt to make the ovary produce more eggs, which of course it can't do. But that's the attempt made by the pituitary to do this. And that's why as a woman reaches beyond this threshold, which, as I say, usually occurs in the late 30s or early 40s, but can occur much earlier, that is when she's starting to develop diminished ovarian reserve, or DOR, which means she's running out of eggs. And again, there's nothing you can do to increase the population of eggs. So as she's running out of eggs, her FSH level at the basal level, early when the period starts, will rise. The normal level's under 9 milli-international units per milliliter. When it goes above 9, it usually means that the woman has got diminished reserve. Sometimes you can have a falsely low FSH, and that happens when the woman's estrogen level is raised, because it's like a teeter-totter. If the estrogen level is high, it pushes down the FSH. And so you get a false interpretation, and that's why it's always important to do both the estradiol and the FSH together, so you can get an idea whether you've got a reliable measurement. The estradiol needs to be under 70 picograms per milliliter in the United States, but using European or Canadian measurements, they use a different measure than picograms per milliliter. They use picomoles per liter, and there it needs to be under 200 picomoles per liter. So when we see a woman with rising FSH above 9 in association with a low estradiol, we know that she's entering the phase of diminished ovarian reserve. And then it's a matter of time. Within a couple of years, and in some cases even months, the number of eggs can plummet downwards, and that's a serious issue. Because the fewer eggs in your ovary, the fewer eggs you'll produce, and if on top of it you're older, then those eggs are not going to be as competent either, and we'll explain that in a moment. So it's important to know that the FSH is one measure, but a better measure of ovarian reserve is to measure a hormone called anti-Mullerian hormone, or AMH. This can be measured any time in the month. It needn't be measured only in the first 3 or 4 days of the cycle when the estradiol is low, because that's not important. You can measure it any time in the month, even when you're on the birth control pill. And if the AMH level is under 2 nanograms per milliliter, that is equivalent to the FSH being over 9. So it tells you that ovarian reserve is diminishing. 1.5 to 2 is still okay. Under 1.5 is problematic, under 1 is serious, and under 0.5 is very serious as an indicator of diminished ovarian reserve. Again, in Canada and in Europe and in Australia, they use a different measure of AMH. We use nanograms per milliliter. There they use picomoles per liter. So again, if we have an AMH of under 15, it's equivalent to an AMH of under 2 picograms per milliliter. If it's under 15 picomoles per liter. And again, 10 to 15 is still a gray zone, but under 10, there's serious problems. Under 5, a lot of problems, and so it gets worse as the levels drop down lower. Again, it's important to understand that when we talk about age affecting the quality of the eggs, and we talk about the number of eggs left, the ovarian reserve, these are two arms, two variables that together constitute the woman's biological age. So if there's diminished biological age, diminished biological reserve, it means that either the age or the ovarian reserve is causing there to be problems with egg competency. Now, I've already explained that as far as age is concerned, it's inevitable, no matter what your ovarian reserve is. Even if you've got an AMH of 4, if you're 45, only 1 in 20 of those eggs is likely to be normal. When you're 42, 43, maybe 1 in 12. So its age is an independent variable of the biological clock. And then there is ovarian reserve declining. If the ovarian reserve declines, the egg should still theoretically be of good quality, equivalent with what age would produce. In other words, a woman who's 40 but has got diminished ovarian reserve could expect to have 1 in 5 or 6 eggs being normal, whereas a woman who is 35, it'll be maybe 1 in 3 that'll be normal. But if the ovarian reserve declines, then egg quality is compromised, regardless of age. And here's why. The hormone produced in the pituitary gland, the sister hormone of FSH that I mentioned earlier, causes the ovary to produce male hormones, androstenedione, dihydroepiandrosterone, and testosterone mainly. So if the testosterone level produced by the ovary is normal, no problem. But if the testosterone produced by the ovary is increased or exaggerated, it can compromise egg development, and then if the eggs don't develop properly, they're far more likely to be aneuploid at the point of after giving the trigger shot. So it's extremely important to understand that this effect of testosterone is critical. A woman's got to have some testosterone to produce eggs and follicles, but if there's too much produced, then the egg quality can be jeopardized. And the production of testosterone in the ovary is largely under the influence of the hormone LH that I referred to. Now, the follicle is the dark area where the egg is formed in, and the egg is attached to the inner wall. And around it, there's a white area that looks like the walls of a honeycomb. Those of you that have had ultrasounds during stimulation will know what I'm talking about. It's the white area around the follicle that's known as the stroma that produces the male hormone testosterone and the other ones. Now, in women who overproduce LH, that connective tissue, that stroma around the follicle, that white area, is stimulated to become thicker and to produce more testosterone. And therefore, women who've got diminished ovarian reserve, who almost always have increased LH, will almost always have increased testosterone production. Now, there's a problem there, because if you stimulate a woman with fertility drugs and you don't do it in a very individualized way, you'll further exaggerate the production of testosterone and compromise egg quality, and therefore embryo quality, and therefore IVF outcome. So it's important during the stimulation to understand there's got to be some testosterone, but not too much. And in my practice, what I do to try to regulate that is I put the woman on a birth control pill leading into the stimulation. And that birth control pill will suppress LH, giving the ovaries a breather so that the testosterone level drops before the cycle begins. And what's important is the testosterone produced in the ovary, not the amount in the blood. And what's produced in the ovary is many-fold greater than the level in the blood. It's almost like pouring a bucket of paint into a canal. And where you pour it in, you'll see the water is stained. If you go 200 yards down and look in the water, you won't even recognize you threw paint in the water. It'll be so diluted out. So it's important to understand that when you measure the level in the blood, you don't get a good indication of what the testosterone is in the ovary, because it's usually much higher, and it can vary how many times higher it is. And if it's too high, you've got problems with egg development, and therefore when you give the trigger shot, you're more likely to have aneuploid eggs, and therefore aneuploid embryos with fertilization, and therefore poor outcome. So the birth control pill lowers the LH before you start. What I then do is I overlap the birth control pill with a drug called Lupron, or you can use Superfact, or you can use Buserelin, or you can use Gonapeptal. They are all the same. They're called agonists, GnRH agonists. I overlap for 3 days. I stop the birth control pill and continue giving the Lupron or the equivalent thereof, and then 5 or 6 days later the woman will have a period. If she doesn't have a period, she may have a little cyst that has to be addressed. But in almost all cases, she'll have a period 5 or 6 days later. And then at that point is when the stimulation will begin. For women that are older and women with diminished ovarian reserve, I usually switch the agonist over from the Lupron to an antagonist. And I call it the agonist-antagonist conversion protocol. For women who don't have diminished ovarian reserve at all, I keep the Lupron going all the way to the trigger. But for women who have diminished ovarian reserve, I will usually switch from an agonist to an antagonist using the agonist-antagonist conversion protocol. And then we'll stimulate the woman, having supplanted the agonist with the antagonist, for the first 2 days with a high dosage, depending upon the woman's ovarian reserve, of FSH-dominant products like Gonlef, Follistim, or Purigon. And I add a small amount of LH in the form of either Luveris, which is recombinant LH, which is not available in America, but is available in many other countries, or Menopure, which contains an equal amount of FSH and LH. So I will add a small amount and continue that for 2 days. And on the 3rd day, I will halve the dosage of the recombinant FSH and double the dose of the Menopure, and continue with that until the follicles are ready, and then trigger with HCG or Ovidrel, which is also HCG, only it's recombinant HCG. And I'll trigger with HCG 10,000 units of Pregnal, Profasi, or Pregnal, Profasi, or Novarel, and or in turn with using Ovidrel, but not one vial, which is 250 micrograms, rather 2 vials, 500. 1 vial is too little, 2 vials is ideal, 5,000 units of HCG, Pregnal, Profasi, Novarel is too little, 10,000 units is ideal. And then 36 hours later, go and remove the eggs, and this is done under conscious sedation. The eggs are then fertilized by injecting 1 sperm into each egg, using a procedure called intracellular sperm injection. The embryo is fertilized and allowed to continue to blastocyst. And in older women and women with diminished reserve, I usually recommend PGT or PGS, same thing, where we actually count the chromosomes in the blastocyst on day 5 or 6. Embryos that don't reach blastocyst are aneuploid or abnormal anyway. And so there's no point in putting them back earlier, which is why I feel so strongly that women should go to blastocyst, because it's at the blastocyst stage that we also biopsy the embryos to do PGT, PGS. And then the DNA is sent off, takes 10 or 12 days to get the results. When the results come in, we sit down and talk to the woman and her partner about what they want to do, because they will have a binary choice. They either put the embryos back as soon as possible, and that is very much influenced by how many babies they want to have over time. And they either do that, in which case we take 1 month's break to let the ovaries recover and then do a frozen embryo transfer. Or they decide to do what is often advisable if they have the financial and emotional wherewithal to do so, which is to keep those blastocysts frozen in a vitrified state, which is an ultra-rapid freezing process that doesn't harm the embryos in any way, and most of the embryos, 90%, will survive the freeze-thaw in the condition they were when they were frozen. So we can hold them indefinitely, and over several cycles bank and stockpile a number of blastocysts that can be used as an inventory that the couple can draw from if they don't get pregnant the first time or they want another baby. Why is that important? Because you've got to make hay while the sun shines if you're getting older, or you're running out of time in terms of the number of eggs in your ovarian reserve. Because if you wait 6 months or longer before you try again, or even if you get pregnant with a child on the first transfer, and then a year passes before you're even ready to consider trying again, you might have missed the boat for another baby. So that binary decision is up to the couple. I will usually give advice of what I think the person should do given the specific circumstances, but it's basically what I said. It's up to the couple to make that decision. So in summary, therefore, what I've told you is this. The ability to be successful in terms of the quality of embryos that you have that are going to be competent depends very much on the woman's age, which impacts, without any recourse, it impacts all the eggs equally, regardless of how many eggs you produce. It will impact it, and so it depends on the woman's age and on her ovarian reserve, because the lower her reserve, the less eggs she'll produce. And if she produces fewer eggs, and especially if on top of that she's getting older, then both these factors of age and ovarian reserve combine to compromise egg quality. And then because of what I told you about ovarian reserve, which is something that you can manage if you use a proper protocol, an individualized strategic protocol of stimulation, and avoid the one-size-fits-all recipe approach, which oftentimes does nothing but adds to the problem by increasing LH and testosterone production in the ovary. If you use that individualized approach, you can give the eggs that the woman produces the chance that would be determined by her age. In other words, if she's only going to have 1 in 10 eggs normal, she's still going to have 1 in 10. She's going to have 1 in 10 eggs normal if you stimulate her correctly, but far fewer than that if you use a one-size-fits-all recipe approach that doesn't regulate LH production. So the protocol chosen for ovarian stimulation in women that are older and women with diminished reserve is central. Let me repeat, central to success with IVF in older women and women who are running out of eggs. You can't use just any old protocol. Therein lies the biggest problem, I believe, in treating women with ovarian reserve issues and older women. So success rates with IVF in older women and or regardless of age, women with diminished ovarian reserve is very much tethered to the protocol you choose and select for each individual patient. And the dosage and regime will differ from woman to woman. There's no one size fits all. But ultimately, when you get the embryos in such women, you need to seriously consider doing PGT, PGS testing of the embryos to see which ones are normal. Because the chance of getting pregnant in a woman, for example, of 45, if we put blastocysts up to 2 of them in the uterus, is in very low single digits, percentages. Whereas if you know that the embryo you've put back was chromosomally normal with exactly 46 chromosomes, then that embryo will probably have close to a 40% chance of achieving a pregnancy in a woman of 45. But hell may freeze over before you get to such an embryo, but at least you know where you are, where you're headed, and how you should proceed in terms of banking to get more or going ahead with the transfer. Now, one last point. You often hear the term used called mosaicism, which I've addressed in a totally different and separate video. Mosaicism is when some of the cells in the embryo or the blastocyst are normal and the rest are abnormal. Many mosaic embryos will autocorrect in the uterus, but the chance of a woman in her 40s having mosaic embryos is very small. There are two reasons embryos can be chromosomally abnormal. The one is because the egg was abnormal, as I've explained in the preceding 40 minutes. But there's another reason. An egg can fertilize normally and make an embryo with perfectly normal chromosomal cells with perfectly normal number of chromosomes in it, say 46. But then as these cells multiply through mitosis, as they replicate, some of them undergo mutation, and you end up with some of the cells being abnormal, but the rest normal. This is what we refer to, what we're talking about when we refer to an embryo as being a mosaic. Some of these cells are normal, and some are abnormal. And those embryos, if placed in the uterus, will autocorrect, and the woman will still have a healthy baby, with the normal cells overwhelming the abnormal ones, and the baby being perfectly normal. However, on the basis of what I've told you, you'll understand that since the chance of an egg being normal is so much lower in older women, so will the chances of any embryo tested as having chromosomal abnormalities ending up being mosaic be also very much reduced. In a woman at 45, where only 1 in 20 eggs are normal, if you then have a blastocyst that you biopsy and you get an abnormal chromosomal makeup, the chance that that embryo is going to end up being abnormal because of mosaic is very much less than if the same looking embryo was obtained from a young woman in her early 30s, where 2 in 3 would be normal. So I usually ask women in their 40s to virtually ignore the issue of mosaicism, because placing back embryos that are abnormal, even if the lab suggests that they look as if they're mosaic because it's not a reliable test to make that diagnosis, I usually advise women to really forget about putting those embryos back if they're older, because the chances of it really being mosaic and able to correct in the uterus is that much lower. So I know this is a complex issue, and we can discuss it in greater detail as it might pertain to your case, specifically when we have our online consultation. But I hope this is helpful to give you a better understanding. Thank you very much for your attention, and I look forward to meeting those of you interested in having an online consultation with me. God bless.